Hello and welcome. We're getting started a little bit late today. Okay. But I want you guys to go ahead and come into session and tell me who you are and where you're from. We've had a lot of people contact us that said that they are in class today, so they're going to join us later, so they won't be joining us right now. But go ahead and come in and just kind of tell me where you're from and what nursing school you're going to and kind of what you're hoping to get out of this session today while people are kind of joining in. And then I'll have a chat with you guys and kind of talk about what we've done and where we're headed and so on and so forth, okay? So come on in. Now, since there's not going to be as many people joining us live as there was last week, I'm expecting you guys to bring your A game and talk to me. Otherwise, it's going to be a very long session. So I need to know what you know. All right. So when y'all come in, once you're actually joined into the session, let me know who you are and where you're coming from, and then what you hope to get out of today's session. So that way we are sure to cover everything you want to know, all the lingering questions about cardio labs. Hey Vicky, welcome into your session. Hi Bonnie. Oh, you're getting ready for NCLEX. That is awesome. Hopefully you got to check out our other ones and that can help to prep you since there's lots of lab stuff on NCLEX. Very exciting. All right, so as people are kind of coming in, remember there is somewhat of a delay. So there's usually about 15 to 20 seconds or so delay, but I'll get to your questions as soon as I can. So my name is Amber Brown. I'm the CEO and owner of Ivy League Tutoring. We are a tutoring school for nursing students. We're located in Texas, but we see students by Skype and online all over the country, hoping to prepare you to be these badass, powerful, like powerhouse nurses. So whenever you get out there, you are equipped and you are ready and you are smart and brilliant and you have learned all the things, okay? So the biggest things what we do here is we're gonna learn the why of what we do, so I can write stuff up here and tell you to memorize it. It will go out of your head very shortly. So what we do here is to always ask why, right? We wanna understand the why behind it, the pathway behind it, so that way it becomes part of who we are instead of trying to memorize things, okay? So today's session is on decoding lab values. This is our cardiac session. Part one was CBC, so we decoded the entire CBC, what's included in that, kind of what happens with that. We did part two, which was our GI lab, so we decoded everything GI from pancreas and liver and gallbladder and all those kind of things that go with the GI system. Part three we did last week was our kidney lab, so we did the GFR and we did BUN and creatinine and ammonia and all these different kinds of things. So if you missed any of those, we will be releasing the entire series as soon as we're done with it. We're going to do a couple more just to make sure everybody is set and ready to go on lab values. That tends to be something that's not taught heavily in nursing school, but something that you guys need very desperately. So as soon as we're done with the series, we will re-release it and it will go out onto our videos on demand, which are available on our website. So if you like what we do, if you understand how we talk, if you can catch up with my Texas accent and see how quickly I talk and you're able to catch up with that and you like how we teach, we have an entire video on demand series that you can go in and either just get what you need for that specific class or for that specific topic, congestive heart failure, seizures, whatever it is, or you can go to our lifetime membership, which gives you access to our entire video library for as long as you shall live, okay? And there's lots of VIP perks to that as well. So I wanted to mention that to you guys so that way you know. And also this will be available for the next 24 hours. All of our free videos are available for an entire 24 hours. So if you're in clinical or you know, you're just Netflix binging and can't be bothered to engage your mind for just a minute, because I usually can't. Last night I stayed up till 1 in the morning watching this new Netflix show. It was a mistake in retrospect. My children got up at 6:45 just to hang out with me because they like me or something. So it's gonna be a good day. I've had lots of coffee. So we're gonna go ahead and get started today, okay? And we're gonna talk about our cardio labs, but I first need to hear from you guys and kind of understand what you already know. So tell me any kind of fun facts that you can remember about cardiac labs. Tell me just, oh, I remember troponin this, CKMB this, okay? So, excuse me, tell me what you already know. What can you remember about different kinds of cardiac labs, okay? And then we will figure out all and decode all the different cardiac labs, okay? So tell me what you know. Type in the comments, let me know. Oh my gosh, please tell me y'all know something or else we're going to have a really long day. Hit me with your best shot. Okay, so far nobody knows anything, which is great. We can learn today, okay? So, most important thing before we start cardiac labs is to talk about the heart and what it does, okay? So we're gonna go into a little bit of patho, because if you don't understand patho, you most definitely will not understand the labs that are associated with the patho of the heart. So always tell our students the patho always comes first. No matter what you're doing, understand the patho behind that organ, that disease process, whatever it is, and all the signs and symptoms and all the nursing care follow beautifully with that. So just a couple of concepts I want to point out before we get going. Please remember, I'm not an artist. Remember, I know if y'all have done this with me before, you know God did not bless me in this area, okay? Very rudimentary heart, obviously. But the biggest things you need to understand about the heart is this here is the heart muscle. Now that is like, and you also have the pericardium out here too, right? So you've got pericardium, which is our protective sac. It's kind of the skin of the heart, okay? Then this layer here is the myocardium, which is the muscle layer, okay? And then inside of here, you've got the endocardium, which is the inside layer. Why am I telling you this? Because it's very important, okay? Most of the stuff we are testing on in the heart has to do with the muscle layer, because if the muscle of the heart doesn't work, neither does the heart, okay? So myocardium is pretty much where it's at. This is the muscle that pumps the heart and has that pumping activity. Keep in mind too with the heart, this pumping activity is mechanical, right? So that's a mechanical way that the heart is actually pumping, okay? But we also have electrical activity in the heart. And both electrical activity and the mechanical activity have to be working well in order for the heart to pump, okay? Last concept we absolutely have to go over. In order for any tissue, any cells in the whole entire body to work, they have to have blood flow, they have to have perfusion, they have to have oxygen, right? So this muscle layer here has all these little arteries that provide it with oxygen and blood supply to keep it working correctly, okay? So what can happen when we have cardiac issues is we have something wrong with the arteries that are supplying blood flow. And if the arteries are not supplying blood flow to the muscle, what happens when you don't get perfusion and oxygen to something? It dies, okay? And so will your patient. So we're trying to prevent that. So a lot of the labs too are gonna revolve around finding out what's going on with the blood supply to the myocardium. And this blood supply here, these arteries are called coronary arteries. They are on the outside of the heart, okay? A lot of people think coronary arteries, oh, it's a blood supply, it's how the heart's pumping. It's not. The mechanical activity that's going on is happening with mostly the myocardium, that's our pumping. And the myocardium only works because it has arteries called coronary arteries that perfuse it. So when you have people, you probably heard friends and family say, oh yeah, he had open heart surgery and he had a 90% blockage, so he's having a quadruple bypass. So a bypass means that something in here is so blocked, okay, with stuff, plaque, hamburgers, pizza, whatever it is, okay? It's so blocked that they can't even do an intervention to get anything in there to open it. So they're gonna have to put something in. They will take a vein from the leg and they will bypass this area and then reattach to the artery, okay? And then they're gonna cauterize this and burn this off. That's when people say, you know, he had a blockage. That's what that means. And if you have a blockage in the arteries, they're not getting blood flow, they're not getting perfusion, the myocardium is gonna start to die. And there is a huge cascade of lab values that go along with that when your myocardium starts to die. This is a huge concept you have to understand. This is called an MI, right? Myocardial infarction. Infarction means we're not getting blood flow at all, right? So what will happen when these vessels start to get occluded, that's atherosclerosis, right? So that's a disease process that happens because the arteries become blocked with plaque, with cholesterol and triglycerides and fat and all these delicious things that we have in our diet, but like to, you know, kind of hang out in our vessels, okay? So atherosclerosis is this kind of blockage, but you still have a little bit of blood flow going through. If this keeps getting worse, this could get to where we have a full blockage, okay? And that is gonna cause angina. So we know angina is chest pain, right? It is pain because this hurts. If you're not getting oxygen to something, it hurts, okay? Have you ever like gone to sleep one night and you had a ponytail holder? I don't know what y'all call it in other states. Here we call it a ponytail holder or a ponytail. Anyway, if you get one of those, a rubber band, whatever you want to call it, around your wrist, you know, so you can just pull up your hair at will. Right now it's Texas and it's 122,000 degrees. I was sweating just putting on my makeup this morning. I wasn't even outside. It's very hot. So we keep these around our wrist all the time. But there's been times where at nighttime I wake up because my hand has pins and needles and it is super painful because it has now gotten a little too tight, okay? And it cut off blood supply and then it hurts like all holy hell because my hand is not getting oxygen. It obviously survived so many ponytails because it's still here, okay? But whenever the arteries become blocked or something isn't allowing it to go through, such as atherosclerosis, that forms angina, that's pain, right? Because we have ischemia. So ischemia means very little blood flow, very little perfusion, very little oxygen is getting to the heart muscle. Therefore, that heart muscle is having some damage and some things are happening. Some chemical exchanges are happening, some byproducts are happening, which we're going to go into every detail of this in a minute, okay? If it continues to get worse and we don't relieve it, let's say we don't take nitro, we don't do anything to increase our blood volume, so this is still blocked, that is what will eventually lead to an infarction. So an infarction means your heart muscle is getting no blood flow. It's already starting to die and get necrosis. Now, what's the problem with that? Well, one, I know it sounds horrible because your heart has necrosis. Like, your heart probably shouldn't die. Even though we've all been through some painful breakups and our heart has died a little bit, but your heart muscle probably still survived, okay? So the infarction means I'm getting no blood flow, I'm getting necrosis, which means there's going to be dead tissue forming because that tissue, that heart muscle is just dying. Well, what happens is all these macrophages and phagocytes come out and they eat that dead tissue, which does not sound like a good job. And in place of that dead tissue, they put scar tissue. Well, the problem with scar tissue, one, it doesn't stretch. So you know how your heart beats like boom, 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 boom? Well, if you've got scar tissue in a portion of the heart, it can't stretch to beat. Therefore, my cardiac output's not going to be very good. My heart's not going to work very well. Number two, scar tissue does not conduct electrical activity. That's also a problem. So it's messing with my mechanical heart and it's messing with my electrical part of the heart. So an MI is no joke. We have to catch it very early. The new standard is that you have 30 minutes from when they come into the door and say, I have chest pain, to get them into the cardiac cath lab. So we've got 30 minutes to do 100,000 different things, okay? And to get the patient prepped and ready for a huge procedure. So you've got to know your cardiac labs and you have to know why you're doing them and understand how to interpret them. So that way I know, okay, can we just hang out for a second because he's not having an MI, he's having heartburn, or I better run faster than I've ever run in my entire life as if someone is chasing me, okay, because we only have 30 minutes until this necrosis sets in and this guy's heart is messed up for forever, okay? So that's one reason why patho is so important that you have to understand. Two, the reason why time is of the essence. We've got to hurry up with these cardiac patients, okay? We don't have a lot of time. Number three, that is how you can understand why we're running the labs that we're running. Is this a mechanical issue? Is it an electrical issue? And I can tell by the labs we're running exactly how much time I have. Is this an MI? Is it some other cardiac disease going on? Okay? So it is vitally important that you understand what we are doing today. Okay? So this is very important for you to know and understand. If you want a whole bunch more details, we've got it. There is a free video on our YouTube channel that you can go to that is entitled Myocardial Infarction. It will go through the whole patho, including atherosclerosis, angina, all the labs we run. It doesn't go into huge details about the labs. We're doing that today. All the medications you're going to get for an MI, what the nursing care looks like. It is a huge resource for you, and there's lots of other free videos on the YouTube channel too, so I would highly encourage you to follow up with that video so that you understand the full picture of MI and cardiovascular health, okay? But this is the basics of what you have to understand today so that you know what labs that we're running and why, all right? So whilst I'm erasing this and getting ready for the next portion, which is when we actually dive into the labs, tell me if you have any questions on what we just covered, okay? And I will answer them in just a minute. And then we're gonna start out with our cardiac enzymes, okay, which is always tested over in nursing school and in NCLEX, okay? So big concepts you need to understand, that's what we're gonna hit first, okay? Does anybody have any questions? That was fast and furious, and I definitely know that. Today, we're gonna hit it. Okay, Perfect. All right. So what we are going to do is we are going to cover our cardiac enzymes. So I want you guys to tell me, what are the cardiac enzymes that you know? What are your big red flags? What are any kind of tidbits you can remember from nursing school or from going over cardiac that you're like, oh, we were not supposed to forget this? What do you know? All right, so we are going to talk about 3 of the biggest cardiac enzymes. First one's going to be troponin, then we're going to talk about CKMB, and then we're going to talk about LDH, which is a huge indicator, but something that we don't always talk about, so we definitely are going to bring that up today. So what I'm going to do is a quick and easy chart for you guys so you can remember which ones you need to run and the purpose behind them. I would encourage you guys to get your own piece of paper and to follow along with me and start writing this down. When you're studying, using different colors, huge big deal. Your brain can remember color better than it can remember words, so that will be very helpful for you. And if you can do it along with me, that will be super helpful. So we're gonna start out with our cardiac enzymes, okay? So we know that enzymes' job is to break stuff down, okay? Or they're the byproduct of something breaking down. So if we're talking about cardiac enzymes, that means something has been broken down in the heart. And as we talked about earlier, unfortunately, it's our heart muscle, all right? So as our muscles break down, as they're not getting oxygen, as they are dying, they produce a ton of byproducts, okay? These are things that are secreted because of muscle damage. That's what your cardiac enzymes are. They are an awesome indicator to tell us exactly or pretty close to when the patient had the MI, because we know we only have a certain amount of time, not only to get them into cath lab, but we only have a certain amount of time to do some interventions like TPA, right? So tissue plasminogen activator, that's our clot buster. We only have 4 to 6 hours from onset of this MI to get that done. So these can help us figure that out. There's lots of different things that can help us figure out. So we start with these cardiac enzymes, and that's what we're gonna start with today. So I want you guys to draw this along with me, okay? And what we're gonna do is talk about some of the biggest ones, all right? So we will do troponin, we're going to do a CKMB, and then we're going to do the LDH. And then after that, we'll talk about a whole bunch of other different things that y'all need to know. Okay, so over here, we are going to do, all right, so over here, I am going to do each of the enzymes. So these are basically byproducts of muscle breakdown because the heart is breaking down because it's not getting oxygen or perfusion. We're going to talk about normal levels, if there are levels that you need to know. I'm not giving you levels today that you don't need to know, that are never on nursing exams, that are never on the NCLEX. But what is more important for you to know for exams, okay, is when these start, when they peak, and when they end. So we're going to talk about their levels, when they start, peak, and then when you would expect them to go away. And the only other time we really see this is when we talk about insulins, right? So we can determine at what point when we give an insulin, when that's the peak time, right, that we would be most at risk of hypoglycemia. It's kind of the same concept here. So we need to understand when it begins, when you would see the levels at the highest, and when it ends, because we're going to follow these trends. This is not something that you do one time. You're drawing cardiac enzymes in succession repeatedly every couple of hours because we're watching to see what the trends of these do so that I can very clearly understand when they have this MI, okay? So it's very important for you to understand the start, the peak, and the end. So the 3 different cardiac enzymes we're going to go over in a little bit more detail is going to be our troponin, which everybody kind of knows a little bit about troponin because they hammer this into you in nursing school, right? And then we've got our CKMB, and then we have our LDH, okay? And this is a different LDH than you're used to. You're probably thinking of like the kind of cholesterol and that kind of thing. And it is sort of like that, but it's a ratio that we're looking for, and we'll cover more about that in a minute. So, troponin. This is now considered the gold standard. Everybody wants to draw the troponin. Everybody loves troponin. They want to marry troponin. So troponin tells us a lot. And the reason why we like troponin so much is because it usually starts, it's one of the earliest enzymes to start or for us to be able to see an elevation in the labs. Second reason being it lasts the longest. So it will be elevated the most or the longest. These would be people that, let's say their CKMB and their LDH was normal, but their troponin levels were elevated, and they said, man, I just haven't really felt very good for the last couple days. We're watching their troponin levels, and we're like, damn, you had a heart attack about 2 weeks ago. Do you remember feeling bad? She's like, oh yeah, kind of had a little chest pain, wasn't feeling so good, but it went away. Okay, so that's kind of why we like the troponin so much, because it will tell us early on, and it will last the longest, so that way I don't miss a previous MI because the other two levels have finally normalized, okay? So for troponin, this is one of the only easy things in nursing school. It should be 0, okay? You shouldn't have any, because you shouldn't have heart damage in any regular given day, okay? The start time of when we're gonna see this start is somewhere between 2 to 6 hours. Some resources that you see will show you up to 12 hours, but it's gonna be an early starter. So we're gonna see it early on in the MI process. It is gonna peak usually at about 24 hours. So about 24 hours after the heart damage started is when we're gonna see it be at its highest. So let's say a patient comes in with chest pain and we draw these troponin levels and they're a little bit elevated, but what does that tell me? I don't know a time frame or how damaged the heart is. 4 hours later, I draw it again, it's gone up. Okay, we haven't even hit really our peak yet. 4 hours later, I draw it again and it's gone up, okay? So that's telling me we probably caught it at a very early MI. And this one will last 10 to 14 days, okay? So we're gonna follow the trend of troponin all the way about 2 weeks after the patient has an MI to make sure that those levels are coming back down to normal, okay? So for troponin, if you have anything greater than 0, okay, it's considered elevated troponin, okay? Very important cardiac enzyme. And remember, cardiac enzymes are happening because the muscle is not getting blood supply, it's not getting perfusion. The heart muscle is then breaking down, getting necrotic, and that breakdown process where my muscle is being damaged produces enzymes. And that's what we're testing here, all right? So troponin used to be the complete and gold standard, and this is where we sort of lived, okay? But the CKMB, LDH, and then we're gonna talk about a couple other ones that have actually become very important and very vital to our patients too. So does anybody know what CKMB stands for? You've probably heard of the CK before, and we do have a CK, and then we also have a CKMB, and it is very important that you know the difference because it could mean a lot of different things for your patient depending on which one we're drawing. The one specifically I wrote up there is CKMB, but I also want to quickly talk about the CK as well. Does anybody know what that stands for? Or even what CK stands for? All right, thank you, Vicky. Creatine kinase, that's right. So anytime you see an ACE on something, an ending, that means it's an enzyme. And we know that enzymes are produced because they're breaking down things or a byproduct of breakdown, all right? So a CK level, we can actually draw for lots of different conditions. So if I know that there's just muscle being broken down, just a regular CK, right? One of the byproducts it produces is creatine kinase. It means that muscle is being broken down. That can happen anywhere in your body, right? I had a patient, when I used to work urgent care, a patient came in as a kid. I do pediatrics, by the way. I'm a pediatric nurse practitioner. So if I say like a kid comes in, it's always a kid. I don't do adult things that much, but I'm working on it. So we had this kid that came in and had been riding a jet ski all day. And the jet ski was just a rough rider, and so he had been shaken all day on this jet ski. So he came in excruciating muscle pain. So what had happened to him was he had been on the jet ski for so long and it had shaken him so hard. He was just a little thing. It caused actual muscle damage. All of his muscles in his body started breaking down, and he got something called rhabdomyolysis, which is a breakdown of your muscle to the point where you build up so much byproduct of muscle breakdown that your kidneys can actually shut down. So muscle breakdown is no joke. The byproducts of muscle breakdown are no joke. This can actually very much harm your patients. So a CK level just tells me that there's muscle breakdown somewhere in the body, okay? Can anybody think of any other conditions other than heart conditions that you would see an elevated CK? There are some big ones, usually very testable ones. Think about pathophysiology of different disease processes that would cause severe muscle breakdown but not cardiac. There's a genetic one that's a big one, and very often on NCLEX. Anybody know? The big genetic one that we look for that causes severe muscle breakdown because of a genetic disease is called muscular dystrophy, Duchenne's muscular dystrophy more specifically. And what it does is it breaks down the muscle and it puts fat in its place, and it eventually will break down all of the muscles in the entire body, causing complete and total respiratory collapse, respiratory failure, cardiac collapse, and then of course the patients will pass away that way. So a CK level we would draw on a muscular dystrophy patient or somebody that we think has muscular dystrophy, because all that tells me is there's muscle somewhere breaking down in the body. So putting that with cardiac, you got to think if a patient is having a heart attack, their CK level will be elevated because their heart muscle is dying, but it doesn't tell me where, right? So what we have here is something called CKMB. Now what does the MB stand for? Anybody know? It's much more specific to the heart, and this will actually tell us that there is heart muscle that is breaking down. Anybody know what the MB stands for? Okay, so the MB stands for myocardial bands. So myo means muscle, cardial means heart, so heart muscle bands. So the bands are the actual bands on the heart muscle. So if we draw a CKMB, then that's telling me, we know the CK tells me there's muscle breakdown. It tells me there's muscle breakdown specific to the heart. So this is a great cardiac enzyme that we can use that will tell us that we actually have a very specific heart muscle damage, all right? You don't have to know the levels, they're very complicated, but you do have to know with an MI that the levels are gonna be elevated. The CKMB is gonna be high. This one doesn't start for about 4 to 8 hours, so it's not as quickly as troponin. So that's why troponin we typically use as more of the gold standard if we're trying to catch an early MI. 4 to 8 hours is when we're going to start. This one's gonna peak the same time, so they're gonna both peak about 24 hours. But this one doesn't last as long, so it's only gonna last about 2 to 3 days, all right? So if we have a patient that comes in and is like, man, I've been feeling super crummy, just not feeling very good, and a lot of our MI patients will just come in with like flu-like symptoms, like my body kind of hurts and I just don't feel good, I've been tired. So when they come in that way and then we ask, do you have chest pain? Well, yeah, my chest has been kind of hurting, and they were like, oh, okay? And then we draw our cardiac enzymes, we draw our troponin, we draw our CKMB, and our troponin level is very elevated, but we have a normal CKMB. Then that's gonna tell me that the CKMB has probably already leveled off. So this patient had an MI somewhere between 3 days and about 14 days, okay? So that will tell me that it's been at least 3 days since they've had it, right? And if troponin is still kind of elevated, then we know it had to have been at least within the last 14 days or so. So that's another example of how we can use this, okay? Use the troponin, use the CKMB to kind of give us a time frame and see what's going on. It can also give us an indication that whatever we're using for the patient, the medications, the treatment, is working because we're having less muscle damage, okay? So you know, when a patient comes into the hospital and we think they're having an MI, I mean, they're going on morphine, oxygen, nitro, aspirin, lisinopril, they're getting calcium channel blockers, they're getting all kinds of different medications in order to relieve the blockage, keep blood pressure under control, and keep the heart working correctly, right? Well, the only way I know that those are completely working is to see, okay, whatever I'm doing is obviously working because these levels are coming down, meaning there's less and less muscle damage, okay? So that's another good indicator for us. All right, so let's talk about the LDH because this one is a little bit forgotten, okay? There are several schools that do still test on it, and it is definitely a good indicator of an MI. But I'm gonna write this over here so you don't forget. This is a late indicator of an MI, okay? So if I think that a patient is having an acute MI and it just started a couple of hours ago, then your LDH is not gonna be super helpful. We're still gonna draw it, of course, because we wanna kind of watch what levels do, all right? But this is a late sign, all right? So it's not gonna catch it early, okay? So the LDH, lactic dehydrogenase, it is usually comes in a ratio. So in a normal, okay, I'm gonna put normal here, in a normal human being that is not having a heart attack, There's two different kinds. There's LDH1 and LDH2. And we look less at levels and more at the ratio. So in a normal, happy patient, has never had a heart attack before, is not having a heart attack now, okay, then a normal is that your LDH1 is greater than your LDH2, okay? That's normal. In a patient that is having a heart attack, they're producing this lactic dehydrogenase in different ratios. So if you're having an MI, then your LDH1 is going to be less than your LDH2. We call this a flipped LDH. So a lot of times on nursing exams, that's what you'll hear. The patient has a flipped LDH, and that's what that means, is that the ratio is backwards from what it normally would expect to be. This does not even start to flip until about 2 to 5 days, all right? So like I said, this is a late sign. It is a late enzyme that is formed. We won't even see it for several days. So if we have a patient that comes into the hospital complaining of chest pain and their LDH is negative, we're not gonna say, okay, you're not having a heart attack. Yeah, you definitely could be having a heart attack, right? It just may not have been 2 to 5 days until we see that flip, okay? This one doesn't really have a peak. It just lasts a period of time where that ratio is flipped, and then it will eventually unflip, and that happens after about 10 days, okay? So these are the 3 biggest cardiac enzymes that we typically look at, okay? It will help us to, remember, help us to determine 1, are they actually having an MI? 2, when did they have an MI? So that way I can determine exactly what interventions I need to do. And then as we continue to draw these enzymes, we're going to see, is what we're doing working? Is there less heart damage? Is what we've been doing effective? Okay, should we continue this treatment plan, or are we just not doing well here? Okay, so those are the biggest cardiac enzymes you need to know. Those are the levels that you need to know, okay? And now we are going to go into some of the other cardiac labs that we would draw that are not just specifically enzymes, okay? Does anybody know any other major cardiac labs that we draw if we think the patient has a heart problem? What are some other labs that we would consider drawing? And give me a rationale why. Come on, I know y'all know stuff. Work with me today. Help me. Any other labs at all? Anything at all? Cool. Ah, yes. Okay, somebody said something. D-dimers coming out and ejection fraction to determine how much blood is pumping out. Very good. I love that. Okay, so a couple things we would consider doing. Another big level, this is not a cardiac enzyme. This is just an enzyme that happens. There's something called, let me write this in a different color, myoglobin. What do you guys know about myoglobin? Or do you know about myoglobin? Well, myo means muscle, so we know it's got to be something muscle. All right, so myoglobin is a byproduct of muscle breakdown, but this can happen anywhere in your body, and it is not specific to the heart. So when we draw myoglobin levels, if we're absolutely sure this is a heart thing, then okay, we can kind of use these levels to determine what's going on. If the patient's had trauma and all kinds of things going on, we may not be able to determine exactly if it's heart related or not. So myoglobin is a byproduct of muscle breakdown, and this can happen for tons of different reasons. We see this happening in shock whenever their muscles start to break down and we switch metabolism, okay? We see this in kidney patients if they've had kidney failure, if they've got a kidney injury, okay? So anything that can end up causing some kind of muscle damage, all right, this could even be trauma. Lots of trauma this can happen with. One of the byproducts of muscle breakdown is called myoglobin. Now, the myoglobin in and of itself is not dangerous. The problem that happens with the myoglobin, the molecules of myoglobin are about this big, okay? And your glomeruli of your kidneys are about this big, okay? So when the myoglobin, which it's a byproduct, right? So your kidneys are responsible for getting rid of byproducts. So as the myoglobin tries to travel through this teeny tiny glomeruli, it either rips it tears it damages it, or it can't get through. It's going to damage the kidneys. So the problem with myoglobin is as it's trying to be excreted through the kidneys, it can cause our patients to go into kidney failure. So patients that are having a massive MI with massive heart damage and muscle damage, they're producing all this myoglobin. Your kidneys have to get rid of it. As your kidneys get rid of it, the myoglobin basically shreds their kidneys on the way out, and our heart patient can now be also a kidney patient. So you have to watch myoglobin levels. And really, really important about myoglobin, okay? It is one of the earliest indicators, okay? So it will happen even earlier than troponin. It can start almost immediately as soon as there is muscle breakdown. The problem is it's not specific, okay? So that's why I didn't include it in our specific cardiac enzymes. It is a great indicator, it is an early indicator, but it is not specific to the heart, okay? But if we know our patient's having a massive MI, let's say they have a STEMI on the EKG, we're seeing it unfold and it's happening and their myoglobin is super high, you better watch those kidneys. Okay, so in our heart attack patients, we have to monitor BUN, creatinine, urine output, watch their urine. If you have a heart attack patient or a patient with any muscle damage, you look in their Foley bag and all of a sudden it's bright red, it looks like blood, that is bad, which you probably knew was bad anyway, but now you know why it was bad. That means that myoglobin has been, that is a byproduct of the muscle breakdown. It's now trying to go through the kidneys. The kidneys are now just basically hemorrhaging. All this myoglobin is coming out, myoglobin is red. Okay, so we have to watch kidneys in our heart attack patients, okay, especially if there was massive damage. All right, next thing you also want to check, we talked about CK a little bit, we talked about the difference with CK and CKMB. Now, since we said the thing that starts this whole cascade off is atherosclerosis, which is the buildup of plaque and fat and triglycerides and pizza and burgers and all those things in the vessels, it is very important for us to draw, oh, this is a bad marker, I can already tell, a lipid panel, okay? What is included in the lipid panel and why would I draw it? Now, FYI, a lot of the ones that I'm going to mention, or a couple of ones I'm going to mention, we went into great detail in some of the other sessions. You want to make sure you catch that. But what is a lipid panel? What are we doing it for and what's included? And some places you'll hear it called an FLP, fasting lipid panel. But if patients are coming in and we think they're having a heart attack, we're not going to be like, well, we're not going to draw this because you haven't been fasting. Like, we just going to draw it, okay? Oh, Corinne, I'm so glad you're here. Nobody's talking to me today, and I'm feeling really sad. Okay, triglycerides, HDL, LDL, cholesterol. That will tell me exactly what's been building up in this patient's vessels. That will tell me how bad the atherosclerosis is. So if I send off a lipid panel and their triglycerides are 500 and their cholesterol is 350 and their HDL is low and LDL is high, we'll be like, oh, okay, now we kind of see what caused this heart attack. This is an atherosclerosis issue. I need to get in there, clean out those vessels from all the plaque, and then get out, okay? So that's why we would draw the lipid panel to see, is this an atherosclerosis thing or something else going on? Yes, I'm mad at you for being late, so I'll probably never talk to you again. Just kidding, I love you, come back. All right, so we talked about myoglobin, we talked about the lipid panel. Now tell me, why would you draw LFTs on our cardiac patients? What are LFTs and why would you draw them? LFTs, what do they stand for and why would you draw them? What's included in them and what will this tell us? Literally, tell me anything today. This is the most painful session because nobody's talking to me. Please talk to me. What y'all got? Liver function test. There you are, my friend. Liver function test. All right, so liver function test. Why would I do these on my heart patient? Why does that make sense? Well, if we think about heart patients, most of them do have some degree of atherosclerosis, right? That's probably a lot of what kind of started off this heart cascade. Atherosclerosis, we know, is caused by cholesterol, triglycerides, all these kind of things. How do we treat cholesterol? We give them statins, right? Statins are notorious for being liver toxic or hepatotoxic. So it's important for us to kind of understand how is the liver doing. Plus, we're breaking down all these different byproducts, and whose responsibility is it to metabolize those byproducts and send them on over to the kidneys to get rid of? It's our friend, the liver. So I kind of need to see what our liver functions look like so that I can make sure liver is healthy enough to give medications, okay? So we want to see their triglycerides and all of that with a lipid panel, if they're on a statin especially, but even if they're not, I need to see how healthy their liver is so that I can know what to do with my patient, okay? It is poor practice to ruin their liver when you're trying to save their hearts. Like, we want to save like all their organs at the same time, okay? So liver function's super important to do, okay? The next thing I'm going to write up here, which you guys should be familiar with this, and this was the topic of our first decoding lab values, is our CBC. Now, I want to caution you with this in nursing school, all nursing exams and the NCLEX, okay? Students love to pick the CBC as a baseline or to just see, and I'm like, just what are you trying to see? Like, you got to have a rationale for what you're doing. So you have to very clearly understand what's in the CBC and what you would expect to see if a patient has a major heart problem. So let's say this patient has or is having a heart attack. Why would I want to draw a CBC, and what will that tell me? What am I looking for? Think of all the different things that are in a CBC. And this one's actually really kind of cool because there's a lot of things we could do a CBC for a heart patient. A lot of nursing care that's coming up that I need some components of that CBC in order to move forward, okay? Okay, so Krim came out and said, okay, we have red blood cells, platelets, and white blood cells, okay? Hemoglobin and hematocrit, those are all included in the CBC, absolutely. So with a patient that's having a major inflammatory response, something bad's happening, your body just automatically starts the inflammatory process and sends out white blood cells. Is this an infection? No, but your body didn't know that, okay? So it's gonna go ahead and send white blood cells out there just in case you need it. So in a patient that's having an acute MI, we're probably going to see the white blood cells in the CBC very elevated. Now those should go back to normal within about 24 hours or so. So it does not mean they have an infection. It means they have a huge inflammatory process. But I do want to see what their white blood cell count looks like. Inside the CBC, we do also have the platelet count, you're right. Now, platelets aren't typically affected with an MI, but what they can tell me is the patient at risk for bleeding if they're too low? Are they too high and we're kind of at risk of clots? Or we may see a whole lot of bruising, okay? So the platelets will tell me a couple of things, right? Because what typically happens when you have atherosclerosis, I'm gonna draw this really quick and then I'm gonna erase it just so you can kind of see it. Let's see. All right, if this is my vessel and I've got all this atherosclerosis, all this plaque build up in here, my body recognizes again, something's wrong, and it sends this inflammatory response out there even though it doesn't know what it's trying to fix. So then your platelets come out like all big and strong and muscular, and they're like, I got you. And so the platelets will come out and aggregate around this blockage. Now what happened though is they made the problem worse. I know, God bless them, they were trying to help. I know that, okay? But they ended up kind of harming in the process. So this aggregation of platelets around the atherosclerosis plaque is the reason we give patients aspirin, because it's an antiplatelet aggregator. It is not a blood thinner. It is not a blood thinner. This is a huge pet peeve of ours at Ivy League, okay? Aspirin is not a blood thinner. It's a lot of things, but that's one thing it is not. It's an NSAID. It's an analgesic. It is a, what else? Help me. Oh, it's antipyretic, right? It helps with fever. It is an antiplatelet aggregator. So it helps platelets to not stick together, but it does not thin your blood, okay? So if my platelets are not sticky anymore and they're not sticking together, instead of congregating all in here, they're just gonna slip right on through past that area of atherosclerosis and hopefully not cause a blockage for us, okay? So, that's another thing the CBC we wanna see. Also, if we said that our goal is from 30 minutes from when this patient comes in to the cardiac cath lab. Cardiac cath, you're making an incision in the groin area. You're going into a major artery, the femoral artery, and you're feeding this catheter all the way up these arteries into the heart and like peeking in there, hello, let me see what's going on. Well, your risk of bleeding is probably high. So we're gonna go ahead and draw a hemoglobin and hematocrit to make sure you're not already bleeding somewhere and make sure that that is just good and happy, okay? And we'll also probably do a type and cross when we draw that too, just in case we nick a little something while we're in there in cardiac cath, we've got the right blood for you to save your life, okay? So, components of the CBC we need to look for. Increased white blood cell count from inflammation. Let's look at our platelet count and make sure we're okay with that. Let's look at our hemoglobin and hematocrit in anticipation of going into cardiac cath. Okay? So that's the CBC. All right. We are also going to draw ESR and CRP. Does anybody know what these stand for, what they mean, and how we interpret them in our patients? What y'all got? ESR, CRP. ESR, CRP. You need these for all of nursing school. They ask these all the time. They ask them on NCLEX all the time. So you need to know what these are and what they stand for. Vicky, you said ESR earlier. Tell me what it stands for. Okay, y'all are speaking to me and I'm so happy. Okay, Karim came through with the CRP, which is the C-reactive protein. Ashley came through with the erythrocyte sedimentary rate, and Vicky says they're inflammation in the body, so you're all three correct. I'm so proud of y'all right now. So, ESR and CRP are generic markers. So remember, that will tell us if there's inflammation anywhere in the body. So let's say a patient was in a motor vehicle accident, they got severe trauma, and we also think they may have had a heart attack. Well, the ESR and CRP probably aren't going to do us a lot of good. They have obviously a lot of inflammation in the body from the trauma. So all ESR and CRP tell us is there's massive inflammation, but we're not going to tell you where. You're like, okay, well, that's not very helpful. Like, you'll see ESR and CRP very elevated in rheumatic fever, right, which is an inflammation in the heart valves. You'll see ESR and CRP be elevated in rheumatoid arthritis. That's inflammation, massive inflammation in the joints. So all this will tell us that there's a major inflammatory response going on, which is happening, obviously, in a heart attack, okay? So they're helpful, but they're not super specific helpful, okay? The next thing that I definitely would want to draw for my heart patient is a BNP. Now be careful with this one because there is something called a BMP. That's a basic metabolic panel, and that's all your electrolytes. A BN is different. Does anybody know what the BNP stands for and what it tells us? BNP. What is it? Now, levels are actually important to know for this, and it's actually very testable for nursing school and for the NCLEX, so you definitely want to know your BNP levels, which I'm going to pop up there for you, so worry not. We're also going to take a picture of this and make sure it's posted so you can have it for all of eternity. Print it out, sleep with it, love it, learn it, okay? BNP. What is it? BNP. What you got? I know somebody knows. I know it. Must be like a 7-year delay. Oh, okay. Thank you, Krim. It is either, you'll see it called several different things. Either a brain natriuretic peptide, you're absolutely right, or some people will call it a B-type natriuretic peptide. Now, you have to know this one because it's not a cardiac enzyme, so I didn't put it in here, right? It is an enzyme, because these enzymes are produced with muscle breakdown. So these are like our MI, like cardiac enzymes, like your heart muscle not doing so good. The BNP is a little bit different because instead of it producing enzymes because the muscle is breaking down, it's producing this BNP enzyme because the muscle is stretching. So the more your muscle stretches, the more it produces this BNP, which is kind of like a protein. It's a byproduct of heart muscle because those muscles are like stretching, like, you know how like when you're trying to get into like last year's jeans and it's like not happening, but you're like determined to make it happy or determined to make it happen. And as you're like pushing in, you're like damaging your legs in all kinds of ways because I've had some serious injuries from trying to get into jeans before. It's kind of like that, okay? So as the jeans stretch or as the heart stretches, it's producing this peptide, okay? So BNP, we will run if we think the patient's having an MI, but this is a much more accurate determination of heart failure, okay? So I'm gonna put heart failure up here, okay? Because in heart failure, your heart can't accommodate all that fluid, right? You've got so much fluid volume and it's like overworking. So the left ventricle is stretching like huge. And the more it stretches, the more BNP it produces. So a BNP of greater than 100 signifies heart failure. And of course, the higher the number, the worse the heart is, I shouldn't say the worse, the more the heart is stretching, which means the worse your heart failure. So the higher this number, the worse your heart failure. Anything over 100 is considered indicative of heart failure, okay? Now, some patients can have an elevated BNP even if they're having an MI, because it may be that the MI was so significant that it impacted their mechanical and their electrical activity, and now they're going into heart failure. So that's why another reason why we draw it is to make sure, how bad was this MI? You know, was it so bad that now the patient's in heart failure and it's stretching and it's moving and it's producing all these enzymes and the muscle's breaking down? And, you know, so a BNP is a good way for us to kind of see what is going on with the heart. Okay, the last one I'm going to pop up here is our electrolytes. Okay, so I would draw a BMP, basic metabolic panel, or you could draw a CMP, which is a comprehensive metabolic panel. The comprehensive includes some other things like some of the liver enzymes, glucose, things like that. Why would I want to know electrolytes in my heart patients? Why is that so important? Why are electrolytes really important to know? And they're important to know in heart failure and MIs and any kind of cardiac disease. Why are they important? All right, so potassium is one thing. So potassium does help our heart to beat correctly. Yes, Grim, you're correct. Sodium, potassium, and calcium are all responsible for that heart contraction. Absolutely. So is it important for us to know what our different electrolyte levels are? Because electrolyte imbalances can cause dysrhythmias. They can end up causing fatal dysrhythmias or severe heart failure. So if a patient's heart is in trouble, I need to know electrolytes immediately and correct those, right? Because if I have high potassium and low calcium, I'm in trouble, right? My muscles are doing weird things. My heart is having these weird dysrhythmias. I have to know my electrolytes and correct them, or I can keep chasing, you know, this heart problem with all these different medications when really we just need to correct an electrolyte imbalance. So it goes both ways. Electrolyte imbalances can end up causing major dysrhythmias and major problems with the heart, right? Or major problems with the heart can end up causing electrolyte imbalances. Because if your muscle is dying and cells are dying, they're usually releasing potassium or all of their contents. That can cause electrolyte imbalances. So they go back and forth. So both ways it's going to give me a problem. So super, super important for you to draw electrolytes and correct those, okay? And that's with any heart problem. And you could really put any heart problem up here and we've got a lab for it, okay? Let's say a patient comes in with fever, a heart murmur. They are 8 years old, okay? And they have a new onset murmur, really high fever. Their joints are aching and red and swollen. You listen to their heart and it sounds pretty funky. And they really look acutely ill. What are some labs that I can run to see what is going on with this patient, and what do you think is going on with this patient? They've got a new onset murmur, which is weird. Any new onset, anything makes us nervous, okay? So murmur means there's turbulent blood flow somewhere. What kind of labs would you guys want to draw? And I'll give you the levels and let you figure out what this patient has. I'm going to say it again. They've got fever. They have a new onset murmur. They look acutely ill, not looking very good, okay? They've got very swollen, painful joints. The heart has some weird tones going on, okay? All right, so Krim wants a CMP, a BNP, and a myoglobin. So I drew the myoglobin. Myoglobin is normal. I did a BNP. BNP level is 30, so that looks good. On my CMP, completely within normal limits. You want an EKG, all right? I put them on an EKG monitor and it says sinus tachycardia. So normal sinus rhythm, but they have an elevated heart rate. Most likely because of the fever. Anything else you guys want to know? Obviously they're 8, they're not having a heart attack, right? Anything else you want to know? All right, so I drew a troponin level, and troponin level is 0. All right, Ashley wants a CBC. I did a CBC, and the white blood cell count is 16. Everything else is within normal limits. Anybody else have anything they think they should run? Okay, so you guys are thinking it may be some kind of an infection. All right. What else do you want to know? All right, so LFTs came back completely normal. But the patient's starting to make some really weird abnormal movements. They started breaking out in a red rash all over their skin. LDH comes back with a ratio of 1 greater than 2. I see, Devin, you were looking for that. What are y'all missing? Anybody else have any ideas? Okay, Corinne with the ESR and CRP. ESR and CRP are off the charts elevated. So what do I know so far? They've got a fever and a high white blood cell count. There's probably a huge inflammatory response going on, probably with some kind of secondary infection. What kind of infection can a kid get in their heart that would cause a red rash and swollen, painful joints? This is always on the NCLEX, which is why I picked this case study. It is always, always, always on the NCLEX. Okay, Bonnie wants a history. All right, so history is, it's an 8-year-old female. She is very unremarkable history. Everything has been fine. She's had no major hospitalizations, no major health issues. She had a sore throat a couple of weeks ago and broke out and had a couple of like weird scab-looking lesions on her arms. Mom put some Neosporin on it. Sore throat went away in about 2 weeks. And then she woke up this morning feeling this bad. Karim, you want a strep? The strep comes back positive, as does the ASO titer. Bonnie, you win. It is rheumatic fever, and they always test on this on the NCLEX. So rheumatic fever is a strep infection that when untreated or partially treated, it travels to the heart, vegetates around the heart valves, causing a huge overall systemic inflammatory response, which is what gives us swollen, painful joints. They get abnormal movements called chorea. They get a new onset murmur because those valves are causing turbulent blood flow. They get a high fever because all that bacteria has vegetated around the valves. You know that rheumatic fever requires an injection of bicillin, which is an antibiotic, once a month for at least 5 years or until the child is 18. So it is no joke, okay? So you can see how we can play with some of these cardiac labs in order to get or understand what's going on with our patient, okay? So these are the biggest labs you're going to see for cardiac patients. I want you to be able to understand what you need to draw for your patient, understand why we're drawing it and what it means, how to interpret it. That's the best way to understand labs, okay? So these are your cardiac labs. We'll take a picture of this and post it on the page. This video will be available for the next 24 hours. And then once we finish all of our Decoding Lab Values videos, we will release those onto videos on demand. So be sure to check those out if you're interested. Or check out our lifetime membership, which would be great for you as you're studying for nursing school, NCLEX, what have you. Okay, so if you guys have any questions, you can feel free to post them to the page and we will have our expert nurse tutors answer those questions for you. Anything that we covered today or just any questions that you've had, okay? You guys did great today. It was a little quiet, but that's okay. And then probably tomorrow morning, we will release our Decoding Lab Values Part 5 and what the topic is going to be for that. That will be next week sometime, and we'll let you know how to book, okay? So you guys were fantastic today, and we will see you next week.